Okay, so today we are going to talk about mechanism of oral colonization, dental plaque, and calculus. So I will go to the general ideas of some of these things, and we will talk about it and we will discuss it. I will go into details with the bacteria and the timing and how it works, but I will not go so deep with some connections between the bacteria. Why? Because next semester you will have perio class, periodontology. So in that course I will give you the more complex version of this. Okay? So before that we start, of course I want to apologize because of last week that I didn't come and I couldn't let you know and you have to wait. So I'm so sorry about that, but I uploaded the class into the IMTMU. So please, I know that just some of you have saw this class, so I want to see that percentage to go up within the next weeks, okay? I'm so sorry, but I recorded it, and I hope that you see it, because definitely will be in your midterms, and it will be something important that you really need to know for your next upcoming courses, okay? So I deeply apologize, but I have some personal issues that I had to attend. Okay, so if we go back to today's class, of course we have the first questions. How many times do you brush your teeth per day? You don't need to tell me, just think about it. Do you brush your teeth 10 times, 5 times, 3, 2, 1? Do you only brush your teeth or do you use interproximal toothbrush? Do you use dental floss every day? So why do you use those things? What is the main purpose of using those things, okay? So today we are going to go with some things and some hints that we need to understand if that's why you're brushing your teeth, okay? Is it really necessarily that you brush your teeth 10 times? Or immediately after you eat? Or immediately after you wake up? Or how much do you have to wait so your acidic pH after you eat needs to decrease a little bit so you can brush your teeth? Or how does that actually interferes with your bacteria in your mouth? Or if it's important that you're actually removing all the bacteria that you have in your mouth all the time, every hour, every 5 minutes. Because if that's the case from a bacteria point of view, you should be brushing your teeth pretty much all day, every day. Okay? But that's the point. You will have always bacteria, and not necessarily that means that it's bad. So we need to understand until which point it's bad. So today we are going to talk a little bit about that. So this is the resume of what we are going to do today. It looks complex, so we are going to divide it in two. So I know that you already know from previous lectures that we are going to talk about from bacteria point of view and immune response, okay? So bacteria coming into your body and how does your body reacts to that, okay? So pretty much we know that bacteria, we go, if we see in the upper left, bacteria can come into our enamel, get attached, and then they will grow, they will get more attachment, and suddenly with sometimes we will have some immunological reaction to that. And with time, if we just give it time, that immunological reaction will get rid of some bacteria, but will also destroy bone and soft tissue. And that's the periodontum around your teeth. So those ones are the steps. So if we see it and we describe all those 4 steps in a cascade, it will look like the way that we have it on the right. So this is what I was telling you. I will not go in all the details of this because this is not the main purpose of this class. But definitely I will teach it to you next semester in the period class. So what I want you to focus in this part is that we have an innate and adaptive response from the body. So if we see a step 1, that all the way down we have a step 2, a step 3, step 4, 5, 6, 7, and 8. So if we go from the bacteria coming into our body, we will have a response from our body. And we can go all the way down from a step 1 all the way to a step 2. What does this mean? It means that there will be an active macrophage cells, fibroblasts, mast cells, endothelial cells, epithelial cells, and those ones will be upregulated by cytokines. So the cytokines, I will explain it to you next semester, but definitely those will stimulate a vascular change, some rankle change, also some gene expressions. That one we will also go into details next semester. And we will have an activation of osteoclast recruitment, and that will lead us all the way down to individual immune inflammatory response. So that means each one of you responding to those bacteria that actually stimulate to this cascade, and that will create connective tissue breakdown and bone reabsorption. That will make your soft tissue, your connective tissue, and every part of your periodontal to be destroyed. So we will go a little bit into details in this today presentation. So as you can see, of course, these numbers are not in order. And that's why we have done so many research. And sometimes we can jump from step 1 all the way to step 3. And we can go through different cytokines and amino acids. And we can have different paths like the ones that are 5, 4, and 6. And this one sometimes can lead us all the way back to a step between 1 and 2, or we can have a step 7 that can lead us all the way to step 8, which is an innate effector functions and adaptive effector functions, which always ends with inflammation and soft tissue and hard tissue destruction. So what it means is that there are many paths, and we haven't done a study in them. Each one of those ones have so many ways to get stimulated and released, because there are so many types of bacteria, and our body will respond in a different way when you're young, when you're your age, when you become older, right? So even though if you have the same bacteria, the way that your body will respond will be totally different. So, but we are talking about bacteria all the time and how to get rid of them, and one of the ways that we use usually will be antibiotics, right? So we know that we can get rid of bacteria with antibiotics. So one of the main reasons...
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, porous and thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations to make it into 10 times as much antibiotic. And then you see the different mutants repeat this at 100. And after about 11 days, they finally make it into 1,000 times as much antibiotic as the wild type can survive. And so we can see by this process of accumulating successive mutations that bacteria, which are normally sensitive to an antibiotic, can evolve resistance to extremely high concentrations in a short period of time.
So before that we keep going with the class, I show you this because we will be seeing right now the different type of bacteria that we can have in a dental plaque. And that's one of the things what I was asking you. How do you remove the first ones? You can brush your teeth, right? That's one of the main ways. So the most important things that we need to have is to understand how these bacteria get attached and how we can get rid of them without using other kind of tools. Because if we have use of these tools like we see in the video, like after 11 days, if you just weigh just too much antibiotics, bacteria will just get resistant. And this is one of the things that you always need to have in mind, because what happens usually from a period point of view is, of course, we have patients with some periodontal disease. We will send them and we will prescribe some antibiotics. But the most important things that we will have to do is how to remove those bacteria from those teeth. Okay? It doesn't matter how much antibiotics we use. If we don't remove them, they will just be in there. Okay? So keep that in mind from this class, because it's more about how you remove them mechanically. So that's why it is important that today you learn how do they get attached and how easy it is to get rid of them. Okay? Because other way, if you just go, you just remember how to prescribe antibiotics, yes, it will work. But we as dentists, we represent around between the 8 and 10% of bacteria's resistance around the world. So we need to drop that way at least at half. So of course, as we were saying from previous classes, we are born without any bacteria, but while we pass through the birth canal, we will acquire vagina and fecal microorganisms. And by the second day, we will have anaerobic flora can be detected in infant edentulous mouth. Within 2 weeks, an early mature microbiota is established in the gut of newborn, and after 2 years, entire human microbial flora formed by complex collection of more than 400 types of bacteria. So as we can see, we can have gram-negative and gram-positive, and with time, we will just get more and more of these bacteria. And that's when you are really formed from 2 years until the way that you are now. Eventually, they will just change a little bit depending on the more specific things. Of course, it's an open growth systems. We have an oral cavity, communicates with an oropharynx, and open growth systems. We have different types of organs. We have soft tissue, hard tissue. So it's a beautiful place for bacteria just to grow. We can divide it in 5 major niches. So we can have intraoral, supragingival hard surface, which are teeth, implants. Of course, nowadays there are more, we are having more, restorations, and prosthesis. Then we have periodontal peri-implant pocket with its crevicular fluid, the root cementum, or implant surface and pocket epithelium, dorsum of the tongue, tonsils, and then all the buccal epithelium, palatal epithelium, and all the epitheliums of the cavity. So most species colonize on all above described niches, with the exception of spirochetes, and adherence of bacteria to oral epithelial cells is directly related to its virulence. Of course, oral cavity teeth and implants are unique form, microbiological point of view, for 2 reasons: provide hard, no-shredding surface that allows for the development of extensive structural bacterial deposit from a unique ectodermal interruption. This is the picture, is the cover from the book that I used for today's presentation. And this is the one that we will use for next semester for the periodontology class. So if you can see as the cover, sometimes we see the covers as meaningless, but in this case, the message was really important. So if you can see, this is the structure in its histology. If you can see the dark side of the left, on the left is, he will be the fixture of the dental implant, and all this dark region is the abutment of the dental implant. So this is the sulcus that is created between the soft tissue and the dental implant. And if you can see here, you will have some cement, and of course that will create bacteria's adhesion in this region. And that's really important because, as we were said, that's just a region that is easy for bacteria to get attached, and that's when you have peri-implantitis. And of course, peri-implantitis will go faster. Once that you reach the bone loss, it will move faster than what is periodontal disease. So a special seal of epithelium and connective tissue exists between external environment and internal part of the body, which is this one, and this one is the one that it should protect you, and we will see it today. So teeth are primarily a habitat for peripathogens. Those teeth can be considered as a port of entry of peripathogens. Carcinogenic species like Streptococcus mutans remain restricted to solid surface and are called obligate peripate. So today we will be talking about dental plaque, so we need to give a definition. So one of the main ones and most important ones is from Glickman, because you need to understand, if we see this plaque here decades ago or centuries ago, we saw it as a hard hard tissue, inorganic tissue, nothing living. Some centuries ago, we didn't even know that we have bacteria. So for us, we saw it, and it was something that we can remove. Nothing with life, completely dead. But nowadays, after we have all the understanding and the bacteria, Glickman a few decades ago, he just said that dental plaque is a specific, amorphous, granular deposit which accumulates on the surface of teeth, dental restoration, and dental calculus. So by the WHO, the World Health Organization, we can see that dental plaque is a specific but highly variable entity resulting from growth and colonizations of microorganisms on surface of teeth, restorations, and soft tissue consisted of various species microorganisms entangled in extracellular matrix. So we have different type of bacteria all mixed up that can change with time or with growth. And as we can see it, definitely if we put some SEM, we can see the yellow area region will be the tooth. The purple one or bluish one would be all the bacteria that are on top. That would be your dental plaque. And the red ones are just red blood cells. So we see some response, but it's not that big. So of course, if we're seeing in another one, it will be the yellowish color and on the surface of the teeth, on the enamel. And if we just leave that bacteria just to growth in the lab, they will just look like this, like some slump, all mixture of bacteria with all the fimbrate, and that makes it special. So, but of course, we will be dentists, and we also need to know how it looks clinically. So, defined clinically is a structured, resilient, yellowish, grayish substance that adheres tenaciously to the intraoral hard surface, including removable and fixed restorations. So, sometimes it will have this kind of colors, but the part is that it's tenaciously adhere. So, after sometimes, if you just let it be there, the attachment that these bacteria get to the surface is really difficult to remove. So it's impossible for you to remove it with a toothbrush. Okay? So at the beginning, within the first days, yes, you can remove it with your toothbrush. And that's the most important thing, that you have it under control. You don't need to be removing it every 5 minutes, but you need to removing it constantly. Because once that you leave these bacteria to get adhere, there's no way that you will move it with your toothbrush. So plaque is primarily composed of bacteria in matrix of salivary glycoproteins and extracellular polysaccharides. And in 1 gram of dental plaque contains around 10 to the 11th bacteria. That's a huge amount of bacteria, just 1 gram. 1 gram, maybe if you have seen the sugars that comes in the Starbucks that are the tiny bags, that's 1 gram. That's almost nothing. So if we can see, usually it will look yellowish, and will be supragingival and sometimes subgingivally, but it will be around the connection between the marginal gingiva with the teeth. And of course, as we can see it in this 32 years old man, he didn't brush his teeth for a week. So in the first picture, you can see it on stained plaque. It's not really apparent. Pretty much you will say that the gingiva looks pretty healthy. So you have the teeth looks a little bit like the normal color, healthy color that you will find. But once that you extend the plaque, becomes apparent with stain with a disclosing solution. So the disclosing solution will tell you, well, how much bacteria is on your surface. And you can realize that this person just with 7 days has too much. Can you remove it still with a toothbrush? Yes, it will be hard, but you can do it. So in these kind of cases, when it's this type of adherence, it's not how hard you brush your teeth, it's not how hard is the bristle of your toothbrush, it's the technique in the way that you do it. Okay? You can brush all day, but if you are not brushing the right spot and you are not using the right technique, you can brush with all your force, you can brush with a really hard toothbrush, and you will never remove that. Okay? So that's why it's important that you learn how to brush your teeth, that you check the angles and the anatomy of your teeth and the position that you have. Of course, not all of us has orthodontic treatment with really straight teeth, so you need to be really careful with those regions, and you need to see how you're brushing your teeth and how much dental plaque you're leaving. Now, from another point of view, think about your third molars. If you have your third molars or your last molar in your mouth, think about that distal surface that is in the back part of that region. Can you brush your teeth there? Can you brush the distal surface of your third molars or your second molars? That's impossible. You will never brush your teeth there. Okay? So that's why you also need to come back to the dental clinic, and you need to have some scaling and some treatment so you can remove those regions. There are places that you will never be able to remove. Okay? And that's what we know. If we just let this dental plaque grow, it will get, the adherence will be harder. Okay? And we will see why. So the number of bacteria in supragingival plaque, of course, we can divide it. Is 10 to the 11th. Gingival crevice, 10 to the 3rd, and deep periodontal pockets, 10 to the 8th. Of course, I know that most of you didn't see last week's presentation. So what it means is if you just have your gingiva, right? If you can see that plaque on top of the gingiva, like here, that's supragingival plaque. Of course, we know that we have a sulcus from anatomy. And if we have the sulcus 1-3 millimeters, if the plaque goes inside that sulcus, that's subgingival. And if we have just a little bit of mixture, because of course it's really hard just to make a line between supra and gingival when we take that plaque to see it, that will be a gingival crevice kind of bacteria. So more than 500 distinct microbial species are found in dental plaque. No bacterial microorganism found in plaque includes Mycoplasma species, yeast, protozoa, and viruses. So it's a mixture of everything. So of course, as I was saying, we can divide it as supragingival plaque and subgingival plaque. And as we can see it, all the stainings that we can see above the gum will be supragingival, and all the bacteria that is under will be subgingival. And they will have different type of characteristics. So supragingival will be multi-layer accumulation of bacteria's morphocytes, so it will be gram-positive, cocci, and short rods predominate at tooth surface, whereas gram-negative rods and filaments, as well as spirochetes, predominate at the outer surface. So, of course, gram-negative and gram-positive, we will see it in the next 2 weeks. So Professor Wu will make a presentation for each one of them. So don't worry about them. We will see them more specifically. So at this location, filamentous microorganisms dominate, but cocci and rods are also occur. So dominated by gram-negative rods and cocci included Metis, Sanguis, and Viscus, Naslundis, and Eubacterium species. That will be in the marginal plaque. And the deeper that we go, we will find that it differs in composition from supragingival plaque because of local availability of blood products and low oxygen tensions. Gram-negative anaerobes and spirochetes predominate. So of course, because we are running away from oxygen, right, we will find more gram-negative and more anaerobic type of bacteria. So what is happening there? So the plaque bacteria interaction with tooth surface and periodontal tissue. So of course, if we have our bone, we have the tooth surface, we will have the bacteria's attachment on the surface of the tooth. We will have some tooth-attached plaque, unattached plaque, and then we will have the soft tissue around. Of course, we have the sulcus and junctional epithelium, which is just this more pinkish region. So some bacteria within connective tissue can go through, and of course, that means that is from the bacteria point of view. Of course, our body will just not let any bacteria go in without being unattended. So, of course, here you will see how it looks on the top, the bacteria, and how it goes through to the surface. If we see it more specifically, if we see it with an SEM, which is a scanning electron microscope, so if we just let this biofilm grow in 10 days anaerobically, we will see that we have just many different type of shapes, sizes, so that means that we have a huge amount of different bacteria just in a community. Of course, from the previous class that I recorded from last week, you will understand a little bit the classifications that we will have, and I will show you later on in a diagram something more specific with the names. So this is how it looks. What it means is, like, if you have the surface of the tooth, we will see that later on, the first bacteria that will attach will primary colonizers. Later on, we will have some secondary colonizers, and some of these sometimes will be from the orange complex. I know that this looks orange, but it should be red, okay? So keep that in mind. This is completely red, and this is the red complex where we have the bacteria that are pathologically and that will actually make you have periimplantitis or peritonitis. So P. gingivalis, fortiscens, and then denticola. So what it means is, like, when you have the surface of the teeth, the only bacteria that can get attached to the tooth surface are the primary colonizers, are the only ones that have the characteristics and the advanced part to get attached to the enamel and to the tooth. This one will never get attached by themselves. Only P. gingivalis, and that's an exception. I explained in the previous class. It has some specific characteristics. Sometimes you can find it as a secondary colonizer. So we still don't know pretty much clear, but you can find it sometimes. That's not the rule. It's just the exception. So we have primary colonizers, and then the secondary colonizers will get attached to the primary colonizers. They will never get attached to the tooth surface because they cannot. Okay? So once that you have those secondary colonizers, you will have some interactions between bacteria, and those interactions will lead to other bacteria to get attached there and start competing with one with other one. Okay, sometimes these competitions will be good to each other, but sometimes it will be antagonistic and it will not be okay. So I will invite you to see the presentation from last week that is recorded, because I explain in details these interactions in that PPT. So the environmental parameters of subgingival region is different from supragingival region. So gingival crevice is bathed with GCF, which may contain many substances that bacteria will use as nutrients. So gingival crevice is just a liquid, a fluid that comes out of your gingival sulcus between your teeth and your gingiva. Okay, so that is will lead to low oxygen tissues in the subgingival area, and host inflammatory cells and mediators have considerable influence on establishment and growth of bacteria. The apical border of the plaque mass is separated from junctional epithelium by a layer of host leukocytes, and the bacteria of this apical tooth-associated region show an increased concentration of gram-negative rods. So this means subgingivally we will have more gram-negative bacteria. So biofilm is a highly organized structure, we will see it later, consists of microbe colonies of bacterial cells randomly distributed in a shaped matrix of glycocalyx. Lower plaque layer are dense, in which microbes are bound together in polysaccharide matrix with other organic and inorganic materials. So they cannot attach by themselves one surface against the other one. They get it and they use polysaccharides. Other way they wouldn't be able to communicate or to get connected. We will see that in a second. So on top of lower layer, loose layer can be seen, which can extend into surrounding medium for teeth and saliva. The fluid layer bordering the biofilm has a stationary sublayer and fluid layer in motion. Nutrient components penetrate this fluid medium by molecular diffusion, and the dental plaque biofilm has open fluid-filled channels running across the plaque mass, act as a primitive circulating system. So even though that you have all the amount of cells all together, there's still a space between them, so you can leave nutrients in other type of spaces, so for the polysaccharides, so the bacteria can communicate and they can live with each other. So of course that will happen in an intercellular matrix, which is an organic constituent, consists of polysaccharides, proteins, glycoproteins, and lipids. It's all the space that is between these bacteria. In albumin derived from the GCF, lipid material consists of debris from the membranes of disrupted bacteria and host cells and possible food debris. Of course, this means that cells are always coming in, they are growing, they are dying, and those dead cells will be nutrients for other new cells. So the glycoprotein from saliva, important components of pellicle, polysaccharides produced by bacteria, of which dextran is most predominant, form and play major role in maintaining integrity of biofilm. So the inorganic component of this dental plaque is calcium and phosphate. So other minerals like sodium, potassium, and fluoride. So fluor, sorry. Source of inorganic content and supragingival plaque is primarily saliva. As mineral content increases, plaque calcifies to calculus. So inorganic portion of subgingival fluid are derived from crevicular fluid. Fluid content of plaque is basically derived from external sources and fluorinated toothpaste, rinses, and water. So we have, of course, the inorganic part of it, but also this will help to the bacteria to get attached and to integrate with it. And of course, we will have the organic part of the dental plaque. So I already explained this in the previous presentation, but in a different way that I think that is easier to understand. We will have the schematic representation of the different stages in the formation of dental biofilm. So as we were saying, we see the step 1, we will have the enamel, and we will have a pellicle formation. That means that you have the fluor, you have some nutrients from food that you eat, you have the saliva on the enamel, and that will create a pellicle on the enamel. So the bacteria are transported passively to the tooth surface, where they may be held reversibly by weak long-range forces of attractions. Usually these are the van der Waals attractions, which are just weak. So sometimes, as you can see, just passes transformation. It comes with your food, it comes with the air, it comes with the water that you drink. So bacteria that you swallow, most of them will just go through. They will not get attached. But the few ones that get attached, at the beginning they just have a really weak attraction between the bacteria and the surface. This usually we call it van der Waals forces. That means that the bacteria in the surface, let's think that they are not, the bacteria are not life. Let's think that they are just energy. So the bacteria have a negative energy and the surface has a negative energy. So like if you have a magnet, sorry, they will just negative versus negative, they will repel, right? But if you have a positive and negative, they will get attracted. So what happens is, if both of them are negative, they will repel. But because the bacteria is moving and is just twisting a little bit, little by little, that change in shape and movement will allow also the change a little bit of that energy. So eventually it will be positive and negative. And that's when the bacteria get attached. Also remember that these bacteria have fimbriates that are long kind of extensions from the surface of the bacteria that will also allow to those connections. Also, they have hydrogen on the surface, and that will also allow to this weak connection. And then the last one is usually if you have these bacteria that looks like bubbles. So for example, if you're drinking like Coca-Cola, right, or Pepsi, if you move it, you will have bubbles coming up, right? So you see sometimes that bubbles get attached to each other. They don't make one entire bubble. Just the surface of one bubble to the other one, they get attached. So that also happens. That means that those bubbles are hydrophobic, right? So if it was the liquid between them, because they are hydrophobic, they cannot attach or dissolve into the liquid. But because they are hydrophobic, they will get connected to each other. So also that kind of connection happens between the bacteria and this pellicle. It's just because they are just hydrophobic surfaces, they get attached to each other. It's super weak connection. This is really important because when you have these weak connections, is when it's super easy to remove these bacteria. And that's what it comes into mind, how often you need to brush your teeth. You don't need to be doing it every 5 minutes, but you can do it a couple of hours of each other one, and you will be removing this type of bacteria that are just easy to remove because they are just weak attachment to the pellicle of the enamel. If we don't remove them, what happens? Well, we have a next step. Adenosine receptors, irreversible, specific, short range. So that means that attachment becomes more permanent through a specific stereochemical molecular interactions between adenosines on the bacterium and complementary receptors in the pellicle. So if we have this adenosine, sometimes that will mean that we have some, for example, from sucrose, you can have this kind of element that will help to the bacteria to get a better attachment. So that also when your diet comes into as a modulator, if you're eating too much sugar, sucrose specifically, you can lead to these pellicles and to this type of receptors that will allows these bacteria to get a better attachment, okay? So, of course, then we have a coadhesion, and that's what we were talking about. That's when secondary colonizers attach to the already attached primary colonizers by molecular interactions, coadhesion. So that means that there will be a really specific type of connection. Please, it's in the last week presentation. I recorded it, so please go and check it. So what happens, as we say, the first colonizers are the only ones that are able to have these weak connections with the pellicle. The second colonizers, bacteria, they don't have the structure, neither the energy, neither the characteristic to get attached to the enamel. But they can connect to the first colonizers. And their connection is really strong. Okay? It becomes better, it becomes stronger. And the other thing that you have is that the second colonizers will create a layer on top of these first colonizers. So now that they even though have a weak connection, now they are protected and they are getting some nutrients, and now they will have another type of connection on that pellicle. And if you lead that with time, will become stronger, will become harder, and that's when you start looking at that dental plaque on supragingivally or subgingivally. And of course, once that you have done primary and secondary colonizers, you have interaction between bacteria, and some type of bacteria will become better at that type of competition. And that's when you will start having the red complex bacteria. So primary colonizers, Streptococcus, Actinomyces, secondary colonizers, Porphyromonas intermedia, Leucheri, and Fusionbacterium nucleatum and P. gingivalis. Of course, we can still have the biofilm maturation. So if you just give it time, that's when it becomes mature. And that's when we will start having these interactions, which is metabolic interactions, environment modifications, gradient formations, matrix synthesis, cell-to-cell signaling, and bacterial growth. So when you have all this structure, they protect to each other, you have these interactions, Some bacteria will live better, some will die, and then you will have a better connection between them, and the attachment is stronger. Of course, one that has grows way too much, so we have some researchers that says that some part of this dental plaque will detach and it will go somewhere else and colonize somewhere else. Okay? So all other bacteria possess surface molecule or receptor which fosters cell-to-cell interaction, highly specific stereochemical interaction of protein and carbohydrate molecules located on bacterial cell surface, leading to coaggregation. So we need this type of enzyme that comes from protein and carbohydrates so they can connect to each other. Most coaggregation are among strains of different genera and are mediated by lectin-like adenosines and inhibited by lactose and other galactosides. So, of course, some adenosines will inhibit, lactose will just help. So depending on the enzyme and the type of bacteria, some bacteria will produce some of these, other ones will produce lactose. So that will lead to which kind of bacteria can actually grow. Of course, here we can see it in a coag more specifically. As we were saying, we will have the tooth surface, we will have the salivary pellicum, we can have a statutorine bacterial cell fragment, salivary agglutinin, alpha amylase, and proline-rich protein. So when you have these kind of pellicles, that's when you will have your primary colonizers. As we were saying, these are the only ones that can attach to this salivary pellicle. And of course, then we will have a secondary type of colonizers that get attached to this primary. So they protect to each other and they have connection to each other. This is why it's important that we study coaggregation. Nowadays, we have way more studies. We understand it better. But as we were saying, you have hundreds of different species that changes during time in different regions, so we need to do way more research. And of course, more of those interactions will lead at the end to have these periodontal pathogens that will lead you to have periodontitis, gingivitis, periimplantitis, or any kind of disease that is related to soft tissue and hard tissues. So of course, some of these will lead to dental decays, cavities. Other ones will lead to a growth of dental plaque, depending on the regions where you have. Of course, depending on the disease that you have, it means that one really specific type of bacteria is growing more, or two or three. But it depends on the surface, soft tissue, hard tissues, and that's how you get different type of pathologies if you just let these bacteria to get attached in this process. So pretty much all the bacteria will have this kind of patterns. When you will have these primary colonizers, you will have secondary colonizers, and depending on the interactions, is one specific one creating the problems. So in the growth dynamics of biofilm, we will have that in the first 2 to 8 hours, adherent pioneering streptococcus saturate the salivary pellicular binding sites and cover 3 to 30% of enamel surface. After 1 day, the term biofilm is fully dissolved because organization takes place in it. And after 3 days, plaque growth increases at a rapid rate and then slows down. So please keep that in mind, because that's when you have this idea. You will have more streptococcus saturate every 2 to 8 hours, depending on the other factors that we will see later on, like smoking, diet, lifestyles, if you have some other systemic diseases, obesity, and depending how you eat. So, of course, the more healthier that you are, you can just wait 8 hours and you will be okay. If you don't have time to brush in your teeth, at least if you manage to have a biofilm fully formed after 1 day, this is your limit, because that's when your immune system starts triggering. So after 2 8 hours, you have that bacteria. That's okay. If your body already recognizes, it will not have any immunological response to it, because it just finding like oral microbiota. It's just say, well, it's part of the bacteria that is around this region. We don't care. Okay? But what happens when you have a fully formed biofilm? Then there are bacteria that your immune response doesn't recognize and start attacking. And that's when you start having crevicular fluid coming into the sulcus. That's when you start having an immune response. That's when you start having gingivitis. So your gum start having some inflammation because it's sending some specific type of white blood cells. Okay? Because that's when you start having this response. Of course, it will be minimum. After 1 day, it will be minimum. But that will be your limit. Okay? So never let yourself more than 1 day without brushing your teeth. This is general terms, and this is a rule of thumb, right? It could be, as we said, the more healthy that you are, you will be in these 24 hours. But if you are just drinking, if you are smoking, if you are eating too much sugar, if you are eating too much sticky things, if you have all these problems, that time would be faster, okay? So there is shift towards more anaerobic gram-negative flora, including an influx of fusobacteria, filaments, spiriforms, and spirochetes. In ecological shift within of the biofilm, there is a transition from the early aerobic environment characterized by gram-negative facultative species to a highly oxygen-deprived environment in which gram-negative anaerobic microorganisms predominate. Sorry, here is gram-positive. So we go from aerobic gram-positive to anaerobic gram-negative. So at the beginning, when you start having these primary colonizers, secondary colonizers, mostly will be gram-positive, and they will be aerobic. With more time and more attachment, will be more gram-negative and more anaerobic. Of course, we will have the next 2 weeks for each group. So we will go into details with the characteristic of those ones and which bacteria are those ones. Of course, as I put in the previous presentation, of course, the topography of supragingival biofilm will be modified by the pattern growth where you are. So the pattern changes with two contain surface irregularities, such as groove, cracks, and perimacata and pits. Surface irregularities can give rise to individualized plate growth patterns. That means that depending if you are in a interproximal region, if you are in a fissure of the molars or premolars, or if you have a gingival crevice, the type of bacteria that you will have will change entirely, and it will behave differently. Okay? Because you have different endogenous nutrients, so that will lead to different type of bacteria. So just by changing just a little bit, it can be the same tooth, but just by changing just which region you are taking your sample from, you will have different bacteria. You don't even need to move out of that tooth. So surface micro roughness, rough intraoral surface, crowns, implant abutments, denture bases accumulate and retain more plaque and calculus in terms of thickness area and colony forming units. So its threshold for surface roughness above with bacterial addition is facilitated. So something above 0.2 micrometers. Sorry, here is missing an M. So what does that mean? It means that if you're not brushing well your teeth and you just leave it with time, of course you will have more nutrients, and that pellicle that is on the surface of the enamel will be more rough. So if we have more roughness, we have easier attachment for the bacteria. So the weak connections that we were talking will be easier to happen. So sometimes if you just polish a surface, you can let bacteria grow for a couple of hours, and you will realize that just by making it smooth that surface, it will be more difficult to bacteria to get attached. So this is after some hours. So if you can compare, if you have a rough surface, bacteria are easy to attach. If it's not, because as we said, the first weak connections cannot happen, so bacteria cannot grow there. So this is another thing. You can be brushing your teeth, but with time, with the older that you get, the more rough that your enamel will be. You will have more fissures, you will have more problems, right? And if depending the way that you're brushing your teeth, sometimes you will make micro groove on the surface of the enamel. You will damage it. Or if you are eating this acidic type of diet, that will make some erosions on your enamel, and that make it rough enough so you can have this. So this is why also it's more important. When you get older, you have these visits to the dentist where we can actually polish the surface of the teeth, so it's easier for the patients to keep the bacteria away, and we limit the growth of this dental plaque. Of course, individual variables influencing biofilm formation, heavy, fast plaque formers, so rapid plaque formers demonstration higher proportion of gram-negative, so some people will have higher predisposition to form plaque faster. We were saying it depends on a lot of things, even though we have genetical issues, so in some kind of cases, it will be just easy for some people to have this film grow faster. So in some cases, we will have 35% more than 17% more in a 14-day window of all plaque. So if you find way more plaque in patients with this time of time frame, definitely you will have to take care of them more often in the dental clinic. So there will be older people that will be light, slow plaque formers. So this one you can just see them once or 2 times per year and you will be okay. They will not have, usually most of the time also these people have really good oral hygiene, so you don't have to be worrying about anything, neither them. Of course, as we were saying, intersubject variations in biofilm formation can be explained by factors such as diet, food, smoking, presence of copper amalgam. Of course, nowadays we don't use that much amalgam for our restorations. Tongue and palate brushing, color stability of bacteria in the saliva, antimicrobial factors present in saliva, chemical composition of the pellicle, and retention depth of dentogingival regions. Okay, so you need to put all the local factors, anatomically speaking, all the systemic factors, and all together, so you can understand if your patients have more tendency to have this biofilm formation. So of course, it can also vary depending if it's lower jaw compared to upper, molars region, buccal tooth surfaces are compared to oral sides, and interdental region compared to buccal or oral surfaces. So early in vivo plaque formation is more rapid on tooth surfaces facing inflamed gingival margin than those adjacent to healthy gingival margins. So it means that increase of crevicular fluid production enhances plaque formation. So when you have this type of patient, or even though you at this time, if you just have some minimal plaque and you can put your toothbrush against your gingiva and you can brush well and you will be okay. But most of the patients, when you start having more plaque and more accumulation and you see this inflammation, it will start bleeding. So instantly what people does is to brush away. That means that they don't push their toothbrush directly into there because of course it will hurt, or they will scared that they will hurt themselves more with the toothbrush when they are brushing. So instead of actually going into the region where they actually need to remove the things, they actually leave it there. So this get complicated and get more complex, and when you have a huge inflammation, more bleeding, spontaneous bleeding, crevicular fluid, patients, they just don't brush well. They barely manage to brush primo in this region. So all this region will be completely supragingival plaque, and of course in these cases we will have deep pockets, and that's a nightmare because now your patients need periodontal treatment and needs you to remove all that for them because it will be impossible for them to do it with a toothbrush. As we said, it's a stronger connection and they will never be able to do it. Not from a chemical connection, but also clinically, because they are not able to do it manually by themselves. So recent studies show that subjects' age do not influence the novel plaque formation. So it doesn't depend if you are young or if you are old. It depends how you manage to remove that dental plaque frequently. So free attachment between bacteria and surface, this is unlikely. Even occlusive part of molar's plaque remains after chewing fibrous food. Only negligible differences plaque extension could be observed. That depends on a spontaneous tooth cleaning. That means how your lip and your tongue and your saliva can be removing all these bacteria. So the novel subgingival biofilm formation, recent studies suggest that the complex subgingival microbiota, including most pathogens, is established within 1 week after abdominal incisions. That will happen in dental implants. So it doesn't matter how much you try to be removing the abutment or not, is that you understand that there will be some type of bacteria that will be normal and it will belong to the oral microbiota and is completely okay. It cannot be sterilized. And then a smooth surface, as we say, 0.2 micrometers, we find to harbor less bacteria than less and a slightly higher density of coccoids. So what it means is like, you know that you will have bacteria, but when you put your abutment, when you put your crown, it doesn't matter which treatment you are doing, prosthetically speaking, from OD or whatever, always need to be smooth. Okay? If you have it supragingivally, it doesn't matter what you do, always need to be smooth. So the transition from gram-negative to gram-positive to gram-negative microorganisms observed in the structural development of plaque is paralleled by physiologic transition in the developing plaque. Early colonizers use oxygen and lower redox potential of the environment, which then favors growth of anaerobic species. So this is what we have been saying all this presentation, from gram-positive to gram-negative. And the first colonizers uses more oxygen, so they are aerobic, which all lead to anaerobic species later on. So we have tried to explain this from different type of hypotheses. First, we have ecological plaque hypothesis, non-specific plaque hypothesis. That means that we didn't know if there were specific bacteria creating these problems, and then we went into really specific type of bacteria creating this problem. And of course, now we have a specific plaque hypothesis, which states that only certain plaque is pathogenic, and its pathogenesis depends on presence or increase in specific microorganisms. So it's a mixture of both. We understand that there is some microorganisms, and there will be some that will be really the ones creating problems. So if we have a healing gingiva, health gingiva, we will find reduced plaque, reduced inflammation, low gingival crevicular fluid flow, and gram-positive bacteria. That's when everything is healthy, and that's how you will find it, and it will be completely okay. But the more that you let grow bacteria, you will start having some gingivitis. So when you move into that, you will increase plaque, increase inflammation, high gingival crevicular fluid flow, bleeding, raised pH, temperature, and then that will be environmental changes. And then we can have an ecological shift, as we said, from gram-positive bacteria to gram-negative bacteria. So this happens with some hours, sometimes it will take some weeks, in other cases with patients will take some months, okay? So that will depend on each patient that you have. So the specific bacterial behavior in biofilm, antibiotic resistance, as we saw from the video, microorganisms in biofilm are 1,000 to 1,500 times more resistant to antibiotics in their planktonic stage. The mechanism of this increased resistance differs from species to species, from antibiotic to antibiotic, and biofilm growing in different habitats. So resistance of bacteria to antibiotics is affected by their nutritional status, growth rates, temperature, pH, prior exposure to sub-effective concentration of antimicrobial agents. So as we saw it from the video, in the middle of the video, we have 1,000 times antibiotic, and we still we saw the bacteria growing. So we know that if we just expose them to that, they will just get used to it. Okay, because they are microorganisms, so they can change their DNA really fast and really quickly. They can adapt super easily. Barely an inconvenience. So the main purpose here is, of course, you will learn it from last semester, but the main idea is that you understand that once that you have that dental plaque attached, of course, we already know that it's a hard connection. So antibiotics will help you to improve your patient systemically and, of course, around the teeth, and it will be okay. But the main purpose and the main idea that you need to know is that you need to remove them mechanically. And that's what we will do, scaling and root planning, and that's what we will learn from the periodontal class. But you need to remember that we are doing that exactly because it's the best way to remove all these bacteria, to leave a smooth surface of the tooth, so you can also lead your teeth to be longer term for your patients. Okay? So don't rely too much in the antibiotics. Also, slower growth of bacteria species in biofilm is another important mechanism of antibiotic resistance. Biofilm matrix, although no significant barrier itself to diffusion of antibiotics, but have certain properties to resist diffusions. Biofilm act as an ion exchange resin, removing antibiotics from the solution. So, also extracellular enzymes such as beta-lactamases, formaldehyde, and formaldehyde dehydrogenase may become trapped and concentrated in the extracellular matrix, thus inactivating some antibiotics, especially positive charged hydrophilic antibiotics. So you need to be also careful, because just the list for antibiotics that we can use for this kind of disease, periodontal disease, when we have this kind of dental plaque, is really limited. So we cannot take for granted or let's not abuse from these antibiotics, because once that they get resistant from them, right now we don't have anything on the list. So if they get just resistance because we are always prescribing this same type of antibiotics for this same type of bacteria, we will eventually don't have nothing. So antibiotics such as macrolide, which are positive charged, but hydrophobic, are unaffected by this process. So some macrolides, I know that you will get it from your pharmacology class, are really strong antibiotics, but they are completely useless against this type of bacteria. It's like if you never take anything. So it doesn't matter, you just need to be really specific, and we will see it in the next semester. So super resistant bacteria has been identified within biofilm, and these cells have multi-drug resistant pump that can extrude antimicrobials from the cells. So it's just not that they become really good at one antibiotic, they will become good in all the list. So as we were saying, this is another schematic representation of the type of interaction that occur in microbial community. The biofilm, as we were saying, oral surface like tooth or mucosa, acquired pedicle. We have some gene transfers, some root protection, adenosine receptors that will help to the bacteria to get attached to each other and to the acquired particle. And we will have some cell density dependent signaling, coadhesion, spatial organization. So you saw the SEM image of all these bacteria, and they look on top of each other without any organization. But actually we have managed to understand how they communicate and how they manage to survive between each other one, and it's because all this interaction that they have between them. So high density of bacterial cells in biofilm facilitate the exchange of genetic information among cells of the same species and genera through transition, contagious, and translocation. So bacterial fingerprinting clearly illustrates that periopathogens are transmissible within members of family. Transmission of carcinogenic species from mother to child, and contagious means that likelihood of a microorganisms causing disease after being transmitted from an infected to an infected host. And translocation intraorally is the transmission of bacteria from one niche to another, is called translocation or cross-infection. So you can have it from one teeth to another one, contagious from one patient to another patient, and transmission is what the bacteria will let you have. So like transmission of chirogenic species from mother to child. So of course the current concept of etiology of periodontitis considers 3 factors that determine whether an active periodontitis will occur. So we have been seeing all this connection between bacteria. Now we have all these bacteria in the dental plate. How do we know which one will make us have periodontal disease? So the concept right now, we need to have a susceptible host. We need to have the presence of pathogenic species, only pathogenic species, and absence or a small number of beneficial species. So if your oral microbiota is decreased and you have some pathogenic species, pretty much you will have periodontitis. Now, if your beneficial species in your oral microbiota is not decreased, they will compete with the pathogenic species, and sometimes they will just win. So you will not have any periodontitis. And of course, this will be modified if the hosts have some hereditary, smoking, stress, diabetes mellitus, among other ones, systemic problems. Okay? Of course, as we were saying, if you have resident oral microbiota, they will help you by nitrate no pathway to help to not other pathogenic bacteria to grow. Will help also in the host development, host crosstalk, and colonization resistance. And this is when it's important, because if they have managed to get attached on the enamel surface, they will not allow other bacteria to be attached. That's one thing. And then between the interactions that they have with each other one, sometimes they will compete and they will win against pathogenic bacteria. So the criteria for identification of periodontal pathogens, Koch postulates given by Robert Koch, is a classic criteria by which microorganisms are just causative. That means that that's how you determine it, if they will cause a disease. So must be routinely isolated from disease individually. That means that you need to take the bacteria and growth in the lab. Must be grown in pure culture in laboratory. Must produce similar disease when inoculated in susceptible laboratory animal. So you take that bacteria, you put it in another animal. If you get the disease, pretty much they will give you the disease and will be considered to be a pathogen bacteria. Must be recovered from lesions in diseased laboratory animal. The Streptococcus mutant has been shown to follow Koch's postulate as an etiologic agent of dental caries. So that means that this bacteria has gone through all the other steps, and we always get caries. Okay? So it doesn't matter where you put it, they will just develop them. Cross criteria are difficult to apply in periodontal disease because of 3 reasons: inability to culture all the microorganisms that have been associated with disease, like spirochetes, the difficulties inherent in defining and culturing sites of active disease, and lack of good animal model for study of periodontitis. Of course, we have different stages and classifications. Reproduce that in an animal is super difficult, okay? Because we are just, usually when we diagnose periodontal disease, we are diagnosing the stage of the disease. So if you are in an early stage, it's not a big deal. If you're in the middle stage, okay, it's a chronic problem. If you have developed a high progress disease, you have way too many bacteria, so we don't know which one is it. So, of course, also we have with the culture problem, as we said, the more that you go into the disease, the more gram-negative and anaerobic these bacteria are. So once that you take that sample and you just expose them just a little bit to air or oxygen, they are just dead. And then other times, there are some of these bacteria that are just super difficult to cultivate in the lab. So even though more difficult to try to make studies with them. So we don't understand really well those kind of concepts. We have a general idea, but definitely we need to do some research on it. Of course, we have other criteria, which is better, proposed by which periodontal microorganisms may be judged to be potential pathogens. So which ones could actually make you have the problem? So must be associated with disease as evident by increase in the number of organisms at disease sites, so it's by correlation. Must be eliminated or decrease in size that demonstrated clinical resolution of disease with this treatment. So it means that if you found it with a patient that have the disease, you treat the disease and then you measure if you found that bacteria again. And if it's decreased, oh, it was this bacteria creating this problem. So must demonstrate that hosts respond in the form of alteration in the host cellular or humoral immune response. And of course, that means that your body is reacting to that bacteria and must be capable of causing disease in experimental animal model. Of course, as we say, sometimes it's difficult to control these bacteria and actually create periodontitis in animals. Must demonstrate virulence factor responsible for enabling the microorganisms to cause destructions of periodontal tissue. So, as again, we just don't need to find this bacteria there. We just need also associated with the destruction that is happening in the periodontal disease because of this bacteria. So as we were saying, this is the same as we have repeated during all this presentation. We have unhealthy periodontum. We will find some specific that gram-positive and the small proportion of gram-negative species. If we have gingivitis, microbiota of dental plaque-induced gingivitis consists of equal proportion of gram-positive will be around 56% and gram-negative around 44%, and predominant gram-positive. But once that we move into chronic periodontitis, we have a microscopic examination of plaque from site with chronic gingivitis consistently reveal elevated proportions of spirochetes, and cultivation of plaque microorganisms for this site. Chronic periodontitis have revealed high percentage of anaerobic 90% and gram-negative 75%. So it's a huge shift in the microbes from the healthy periodontum. Of course, if we see it classified in different groups, we will find, as we were saying from the previous classification that I showed you, the most that you find first, primary, secondary colonizers. Then you will have from the orange complex that sometimes can become periodontopagenic. And finally, the red complex, where are always, if you find it, definitely you will have gingivitis and periodontitis, any type of stage. And of course, if we separate it and we compare from supragingival with subgingival, we will see that the percentage are pretty much similar, okay? This is a better way for you to see it, the shift. And this is really specific to periimplantitis, so we can have the implant surface, and we will see also if we separate the bacteria the same bite complexes that we use for periodontal disease or healthy periodontum, we will see the type of bacteria that comes along with it and how they are on top of each other, and we can see that they will start having problems. So in this case, of course, the implant surface we don't is just inert, but of course, if you have all these red and orange complexes just exposed to the epithelial lining of the preimplant pocket, that's when you start having issues, because that's when you have all the immune response. But here you don't have a periodontum, you just have this preimplant pocket tissue. That's why when you have these bacteria, for them it's just easier to go and destroy and have more bone destruction. Of course, they don't destroy the bone, it's your body reacting, the ones that actually destroy the bone. Of course, in periimplantitis, we will have the healthy implants, and as you can see, we will have cocoids and orange non-motile rods, and this will just change slightly with time if you go in healthy implants in subjects with failing implants, or if we just have failing implants. the percentage actually are reduced, and in the other ones we'll just start from this one to this two. They're not much that difference, but they are increased from healthy implants. So if we compare healthy from failure implants, we will see also a change in bacteria. So if you remember from the first slide, all the cascade that I was showing to you with all the steps, the 8 steps, this is the really slight, easy version to understand. You will just have a bacteria coming into your oral cavity. You will have strategies of immune subversion that could go for interleukin-8 inhibition, complement subversions, TLR4 antagonisms, and that will impair the host defense. All that process, what it means is that you go from a symbiotic microbiota, which is normal microbiota, as we were saying, primary colonizers, body recognizes that's something that is always there, into a dysbiotic microbiota. And that's what the body doesn't recognize. So in this one, the tissue has some homeostasis in a periodontal health. In this one, we have inflammation and bone loss of periodontal disease. Okay? So you have the bacteria stimulating your body. You have some interleukin inhibition, TLR4 antagonism, complement subversion, and that's what leads the body immune system not to react. And that's how you change from healthy into a pathogenic state. All that I have talked about today is from chapter 8 from Newman, the 13th edition, and from chapter 8 to 11, okay, so it's 8, 9, 10, and 11 chapter from Linda, which is the 6th edition, okay? So of course, I have tried to resume the most that I can, and definitely I understand some of the things are way better described in the presentation that I uploaded last week between the correlations between the bacteria. Okay? So if you have any questions, you have my email, you can ask me. I will give you, well, here you have the PowerCam. I will just copy it and I will give you the PPT so you can copy it from here today. And of course, you will enjoy more the next courses because we will have Dr. Wu coming, so it's in Chinese, so it will be more interesting. And I know that you will enjoy more the classification of gram-negative and gram-positive. If you have any questions, if you don't have, then we can finish the class today. Thank you for coming. Next week we will start having the assistants, so please let your classmates to also attend, okay?